All right, thank you so much. Yes, this is us. I'm going to start things off, so just thank you for inviting us both. Never done a shared presentation like this before, so bear with us while we hand it off. In terms of disclosures, we don't have any relevant financial conflicts of interest. No one wants to give us extra money for anything. But our work is funded through PCORI, the NIH, the CDC, various grants shown here. And we want to acknowledge the generous philanthropic support of the Bresnowski family, shown here along with our former chair, Dr. Dallek. Just to note also, our photos that you see throughout, they're not real patients, they're staff role-playing, and participant quotes are redacted or rephrased for participant anonymity. We are lucky to have a wonderful team of collaborators here, including many faculty and staff in psychiatry across campus, across the country, really listed here. And this list of our team also includes community partners, namely those with lived experience and family and clinicians, as well as a number of staff. Everyone won't fit on this slide, but we appreciate that this is a large team effort. Just a brief roadmap. I'm going to give a little background underscoring what we do. I'll talk about some of our social media work, telehealth, and portal approaches, and then Maureen will pick things up to talk about bundled adaptive interventions and directions for the field. So we're focused on behavioral health, and that is mental health and substance use disorders, life stressors, and other sort of stress-related physical symptoms. And so behavioral health care is the prevention, diagnosis, and treatment of those conditions. Mental health and substance use disorders affect almost 90 million adults in our country and many millions of children, and there's a high degree of comorbidity as illustrated here through the National Survey on Drug Use and Health. These issues pose enormous societal and economic consequences and are something we're committed to addressing in our work. So with that context in mind, we're going to share some examples of how we're using technology-driven mobile approaches to address these problems. So the work presented today tends to fall, I think, as in two columns, focused on substance use and related outcomes. And first is a focus on prevention. Often in our work, it's secondary prevention in order to alter trajectories away from substance use disorders and other problems for those who are at risk, often focused in our work on adolescents and emerging adults. We also focus on treatment and treatment engagement to promote recovery and reduce consequences for individuals with untreated substance use disorders or mental health conditions. But the how is the same across these goals. We're using technology to help with proactive identification of and outreach to those who could benefit from engaging in accessible interventions. So the work presented today is largely situated at the prevention and treatment spheres of the continuum of care model and largely involves community-engaged approaches where we develop and vet intervention content with people with lived experience. Perhaps no surprise to this audience, technology offers great opportunities to reach people across that continuum of care. Often not just from our health system to our sort of clinics throughout the state, but really to where people are in their day-to-day lives, where change actually occurs. And we're using devices and tools that are now readily available to most people, phones and computers. So motivational interviewing, or MI, is a central guiding force to our work. MI is well suited to behavioral health, so it's efficacious as a treatment for substance use disorders, but really it's broadly applicable to behavioral health. And in particular, we sort of like Ken Resnickow's model, where we're using tech-based tools to support people in identifying why and how to change and meeting them where they are. So to meet people where they are, which is a phrase I've heard a few times today and I think really is emphasized through technology, we can leverage existing platforms that are already used in daily life to deliver behavioral health interventions. And so in our social media work, one of the lessons learned is that I want to stress that it's important not just to pick the platform that's the most popular or of the moment if you're thinking about using social media as an intervention tool, but really to pick a platform that's likely to be acceptable and used by the target population and has the features you need to be consistent with your theoretical model and your overall goals. And I think that's well articulated in this citation at the bottom of the slide by Maureen A. So we've done a handful of studies using social media to deliver secondary prevention interventions for substance use, and I'll give a few examples of those. So our first social media intervention, you can think of it as group therapy for risky drinking adolescents and emerging adults on Facebook. And so this is examples of some of our intervention content. This study was funded in 2015. Maureen was the PI, and I was heavily involved in the clinical delivery in the study. And so we had group-based, again, health coaching, sort of group therapy on Facebook over 8 weeks in secret private Facebook groups where we were using social media content packaged with MI-based questions, reflections, and other skills to deliver intervention content to prevent risky drinking. We had 3 groups in this study. We had a control group, we had an intervention group that received this content for 8 weeks. And then we wanted to test whether we could promote engagement with the content through modest incentives. So participants in another group received the same intervention content, but they were getting a $1 per day incentive if they commented, posted, shared meaningfully in the group. So same content, but trying to get more engagement. And what we learned in that study was we could deliver MI with fidelity in social media groups. We had high acceptability and engagement. There were 955 people enrolled. And although it's an alcohol study, we didn't have any alcohol-specific findings for efficacy, but I want to note the time in which the study took place was when we really saw an uptick in cannabis legalization, availability, and so there was a lot of co-use of cannabis in this sample. And so what we did see was our intervention content, the incentivized condition, reduced drug use and total substance use, so inclusive of alcohol, over 3 to 6 months. And drug consequences, cannabis impaired driving, also reduced as well. And so we were really seeing this as a promising approach because we saw great engagement, we saw some effects, but it's not just what we see in our numbers. We also wanted to hear, we heard what participants had to say. And so here's a few examples of what people liked about this approach. It was great to openly discuss stress, anxiety, drugs, alcohol, and addiction in a non-judgmental setting. And it's been that they've been able to talk freely about drug or alcohol use with no bragging or shaming. They could vent their frustrations, maybe help others or who were having a bad day. So their group interaction with the non-judgmental approach seemed to be really key there. And so as I mentioned, cannabis use really was becoming sort of a bigger thing during the course of this study. And so during that time, we also were thinking, well, we need to do something about that. And so we proposed and led a pilot study through an R34 mechanism from NIDA to address cannabis use in a similar model with the group interventions on Facebook. And what I'll say, because people were interested in hearing about different funding mechanisms, an R34 is an intervention development grant. Not all NIH institutes have them, but that's a mechanism available at some places. And so we did a similar thing with developing a cannabis pilot. We found it was acceptable. The participants found the coaches that they had in these groups as helpful, warm, respectful, understanding. They liked the content and connecting with peers. You can see some of their replies here are redacted again, but they're giving some change talk around cannabis use. They were engaged, so they were posting and interacting regularly. And we saw, these are underpowered pilots, so we saw promising effects, actually a significant and sizable effect on vaping, which hadn't been shown in the cannabis literature yet, that there was an intervention that could tackle vaping, but we were able to do it. And we saw good trends in the hypothesized direction on other cannabis measures. And so this was another sort of way of intervening on substance use and cannabis use that hadn't been tested yet, but is a model we're seeing very much promise from and hoping to sort of sustain and look at in an efficacy trial in the future. So those are our group-based approaches. We've also done individual-focused social media studies using Snapchat. And you can think about, again, when picking a platform, well, what features does it have that makes it work for what you're trying to do? And there are a couple ways in which we felt an individual-focused intervention communication modality would make sense, and they're illustrated in these examples. So, and of course, you can group message on Snapchat now, but there's also a lot of one-to-one communication. And the sort of platform is appealing because of the sort of auto-delete features. It makes it feel more private. So one way we've used Snapchat is as sort of a clinician extender. So we've done a remote delivered MI session to patients in the emergency department who are there for various reasons, but are screening positive for risky cannabis use. And we deliver a brief intervention session and then follow that with 4 weeks of health coaching through Snapchat. So, you can think about extending the clinical moment outside of that first visit, but doing it in a place and a modality where young people go. And so we had another night a pilot to do that. And we had an NIAAA pilot to do a similar 8-week social media intervention through Snapchat for high-intensity drinking. High-intensity drinking is a higher level than binge drinking, so a little more risky and a lot more comorbid mental health issues. So we thought a private one-to-one intervention would be able to be tailored to the severity of the individual and their unique concerns. And so we also did this sort of 8-week alcohol-focused intervention. And both of these studies, we found, again, this was an approach that was acceptable, it was feasible, it was engaging, so people wanted to message back with us or our coaches. And we saw promising effects, again, in terms of mechanisms related to MI, such as intention, motivation, and self-efficacy to change. And we also saw reductions in alcohol consumption and consequences at 4 months and mental health symptoms. And so these were very promising effects again, but I want to highlight also what our participants are telling us beyond the numbers. One of the things that they liked was that it was a familiar platform. So we're not trying to get them to use a new fancy app or go somewhere they aren't already. And that they appreciated the content and sort of the non-judgment again, and allowed them, one person said, to learn to process loss, anger, and complex negative emotions without exclusively self-medicating. And so they, kind of had some similar things to say about that. And I think that really shows that in our alcohol intervention, we were addressing mental health as well. So that's a snapshot of our social media-based work. I'm gonna move on and tell you a little bit about our telehealth and portal-based work. So when I refer to telehealth in this talk today, what I'm meaning is synchronous delivery of clinical interaction through phone or video conference. And when I talk about a portal, what I mean is written messaging using a system that's analogous to the messaging features we have with our clinicians through our patient portals like MyChart with our integrated EHRs. And that's important because over 90% of health systems utilize this technology. So our team has done a variety of work in this space across both prevention and treatment spheres. Our telehealth work was something that we were conceptualizing before COVID, but then COVID sort of necessitated that and really had it take off. And in terms of our portal work, I think that was really inspired by some work led by Cheryl King, who was using a messaging platform to deliver MI to college students with suicide risk to try to motivate them to engage in care for their suicide risk factors. And I saw we were using that. I did clinical supervision on that study and thought, how do we apply this to substance use? And so one key example of both of these is Maureen and I's HEAL prevention study that was funded in 2019 through the NIH HEAL initiative to conduct opioid misuse and opioid use disorder prevention interventions with 16 to 30-year-old emergency department patients here at Michigan Medicine. So this study involved a combination of intervention conditions. Ultimately, we've got 4 groups. So the first intervention was a brief MI-based session with a health coach delivered one of 2 ways. We could have our coach, in an office somewhere pre-COVID, hand a patient in the ER an iPad, and they could do it virtually there. So the idea that you can have clinical staff not crowding the ED, but still able to deliver an intervention to any point in the health system was a feature or something we were imagining before COVID struck, and then everyone was doing this. And the other way it was delivered was, after the ED visit, when participants were at home feeling better or another preferred location. And so a lot of this went from home office during COVID to our participants at home as well. So that was one intervention. The other intervention was our portal messaging, which was therapeutic MI and CBT-based portal messaging, therapeutic messaging delivered over 4 weeks, with our coaches sending highly tailored, personalized messages across a variety of prevention topics shown here. And this was, again, highly tailored. So if someone didn't deal with chronic pain, we really weren't going to message them about pain. We were going to message them about mental health or physical health or sleep if that was important to them. So that was one of the conditions. And although for implementation, it would be ideal to deliver this type of intervention through our MyChart portals or similar systems, for privacy and confidentiality issues associated with research, we worked with our collaborator Kai-Jen at UC Irvine to develop a portal messaging platform that lives outside of the permanent EHR, yet has similar features, similar user experience, a little less cluttery than MyChart, speaking as clinician, but here you can see a clinician dashboard on the left that shows participants currently enrolled and various status updates, like we got a new message from them or how far in the program they are. And on the right is an example of the messaging interface from the clinician view. And it shows common elements you'd see in a EHR, patient demographics, assessment scores that are consistent with measurement-based care, clinical notes and memos, and then the messaging in between patient and clinician. And we've been able to change this technology over time where we can send images as well. So you see one of our newer versions here. So in this trial of these interventions, we enrolled over 1,100 participants over 3 years. And what I'm showing here are the 4 conditions. So the session, the portal, a combined condition, and a control condition. And what I'll point out here is that we had very high engagement and receipt of condition, over 90% across these groups. So people were receptive to these technology-driven but human-delivered interventions. And you see in our portal groups, we had an average of 11 or 12 messages received from participants over the 4 weeks. So we were messaging them at least twice a week, but they were engaging in conversation with us, and we were delivering therapy that was tailored to their needs. And we're in the process, like literally right now, of, we're emailing about it earlier, the analysis of this trial, so I don't have efficacy outcomes. But I do have, again, what participants have told us. And I think the key thing I want to show about these data are that participants liked the portal idea, and so that's something we're interested in driving forward because it allows asynchronous messaging, which people, said, this one quote at the bottom, that they liked having the option to have it whenever life was doing its life thing. As clinicians, we're not always available when life is doing its life thing, but people can message us. And a lot of these are MI-based interventions, and so I want to highlight, the quote on the right where we're starting to see the wheels turn, right? We're not always seeing the big impact when you're doing behavioral health interventions that are brief and time-limited, but what we do look for is people moving a little bit in their thinking and then eventually behavior. So this person on the right is saying that they really started to re-examine their substance use and really ask themselves important questions about it. And so I think we're seeing someone move from pre-contemplation to contemplation and maybe start to move toward action with this type of approach. And so again, efficacy results are in progress, but before I turn it over to Maureen, the last thing I want to do is just highlight our next direction for some of these approaches is to think about combining them and what combinations of different types of technology-driven approaches make sense, who needs what when, as a lot of the D3C folks say and know. And so in a MPI trial, NIAAA R01 with Allison Lin, we're looking at combinations of telephone sessions, portal messaging, and video conference MICBT for people identified with AUD, alcohol use disorder, who are not in treatment. So we're reaching out, assessing, and grabbing people into our interventions who otherwise weren't presenting for alcohol use disorder treatment. And so we're in progress and over 330 enrolled to date. So hope to talk about that at a future conference. And with that, I'm going to kick it over to Maureen to tell you about bundled and adaptive interventions.
Thanks, Erin. I'm really excited to be here today to really think about how technology can be harnessed for both human delivery and digital delivery of different interventions. So for this part of the talk, I'm going to describe 4 clinical trials. The first 2 are really testing bundled intervention programs, and the latter 2 are testing adaptive interventions. So first, Erin and I are MPIs of an ongoing project that is being conducted here at Michigan Medicine as part of a healthcare visit for youth. And what is exciting about this program is our community partners. We have both a youth advisory board, a caregiver parent advisory board, and a healthcare advisory board. And one thing they've told us is that for this project, they want it entirely digitally delivered interventions. And the reason why is for scalability. So the rationale for this trial is that prior research has showed that screening, brief intervention, and referral to treatment is evidence-based for youth presenting to clinics to prevent escalation of alcohol use. However, in practice, it's really challenging, especially in the post-COVID world where there are virtual visits and a lot of other competing demands. So this study, we're funded by PCORI. It's a comparative efficacy study, and we're basically comparing two different bundles of digital interventions. And youth are eligible if they report any past year alcohol use. So it's really prevention focused. I also want to give a shout out to CHCR, who's here today, who helped us develop this program, and Jeff presented earlier. So this digital intervention is web-based. It's entirely on the web, and that way it could be HIPAA compliant. You get a QR code when you come in for a visit. You can do it during the visit. You can stop. You can do it at home on your phone anytime. It includes innovative features that are social media-like, but it's in this digital program, so that way you're not interacting in the actual social media space. And so youth partners helped us develop this. It includes things like TikTok-based peer testimonials and chat rooms and things like that. We're combining this digital program, which you see on the left there, with an off-the-shelf app by SAMHSA called Talk They Hear You. This is an app for parent or caregivers, and it focuses on parental monitoring and parental communication. So we're testing this bundled program with or without 8 weeks of twice daily text messages. The point of that is to see who needs the text messages and can we extend the intervention effects by providing intervention content as youth go about their daily lives. The text messages focus on goals and strengths, coping, social support, leisure activities, and harm reduction strategies to reduce binge drinking, driving under the influence, and overdose. So they're really sort of upstream prevention focused. So thus far, this is an ongoing study. We've enrolled about 1,000 youth and 600 parents. We've submitted abstracts to conferences, and these are just some of the significant variables that are related to youth alcohol use, related to both a youth report and a caregiver report. The point here of this slide is I wanted to emphasize that we have an exploratory aim in this study where we're going to be conducting machine learning analyses to identify markers of both in terms of both youth and caregiver characteristics that inform who responds and who is less likely to respond. And that'll help us really make recommendations for who would benefit most from the addition of the text messages, and that could inform translation. So stay tuned. I'm sorry I don't have results from the trial. So second, I wanted to tell you about a really exciting project. So this is with my colleagues from the Institute of Firearm Injury Prevention. I was a co-I on this study, and Patrick Carter was the PI. And this study we just completed tested a bundled human and digitally delivered program focusing on health and safety for young people presenting to the emergency department. This was in Flint, Saginaw. This study was Flint and Saginaw, yes. The sample includes young people who report any firearm carriage, and the reason why is because 3/4 of this sample engage in risky firearm carriage, and that's defined as carrying while drunk or high, or threatening or using a firearm during a conflict. So the program just combines sort of 3 components. The first is this evidence-based single session called Safer Teens, which is a therapy session that's delivered either during the ED visit or after by telehealth. And it then has 2 care management sessions, which is really focused on resource identification for these youth. And a third feature is the Interact app. The app is given both in the intervention and the enhanced usual care control condition, except in the control condition, all the intervention features are stripped out. So basically they're getting the daily self-monitoring EMAs to complete, and there's resources for sort of risk management, but there's not the intervention content. So I bet you're wondering, what was the intervention content? So this was developed iteratively with feedback from our youth advisors. It includes things like a hope box with the individual's goals and strengths. It has supportive twice daily therapeutic messages. During app onboarding, they select risky situations, and then there's geocoded risky location messaging that happens along with a reminder to do a one-touch call to a support person. It also includes care management resources. There are daily testimonials and a toolbox with various CBT, anger management, things like this, strategies. So what do we find? So this outcome paper is currently in review, that the intervention, the bundled intervention program relative to control significantly reduced our primary outcome, which was risky firearm behaviors at 6 months. And we also found significant effects at 6 months on several of our other exploratory and secondary outcomes, which are things like any violence, substance use, mental health, and criminal justice involvement. So we're really, really excited about this, and obviously there could be implementation would be the next logical step. However, a key challenge is that we don't know how to best combine, sequence, and adapt the components of Interact. Which of the 3 components worked best for whom when? And that's a question we don't know in these bundled studies. This matters because to enhance engagement, we have to reduce burden for participants, especially as we think about use of these apps longer than 30 days, which is a lot of our studies, except people's problems exist longer than 30 days, right? So we really need to think about that, especially because in cost-constrained settings, there may be limitations on what they can provide. So we need to be more parsimonious in terms of delivering just enough for some people and saving resources for later when they might need more. So as a next step, we've submitted a grant proposal, fingers crossed, that to conduct an optimization trial where we're dismantling the different components, and we're hoping that that will, if funded, we will be able to test and find which components work for whom when. So I want to pause just to make sure you're on the same page as I pivot to adaptive interventions. I appreciate Erin mentioning this. Walter mentioned this earlier as well. So human-delivered components are typically delivered on a slow timescale, like weeks or months. And interventions that use adaptation to address conditions that change relatively slowly are called adaptive interventions. This is in contrast to digital components, which are typically adapted on much faster timescales, like you saw in the wearable studies, that can be over minutes, hours, or days. And interventions that use adaptation to address conditions that evolve very rapidly are called just-in-time adaptive interventions, and you'll hear them called JEDIs. We also have a new methodological or experimental design, or relatively new designs called SMARTs and MRTs, which can inform the development of adaptive interventions and JEDIs. And the D3C, who is a leader in this methodology, has developing methods called hybrid experimental designs, which can help us optimize multimodal adaptive interventions. What are those? Those are interventions in which human and digital components are integrated and adapted at different time scales. All right. So I wanted to show you 2 studies. The first is a SMART and the second is an MRT. So in this study, this is the MCOACH study. This was a comparative efficacy study. Also, CHCR helped me develop this intervention. Thank you. And youth from the emergency department were eligible for this SMART if they reported recent binge drinking and they reported aggression. And note, this study did occur during 2 major life events, the Flint water crisis and also COVID. And so unfortunately, we were underpowered in this study. We were thrilled to enroll 400 youth, although it was not the 700 we had planned. All youth received the Safer Teens single therapy session, followed by either one of 2 types of boosters. So they get 4 weeks of telehealth calls once a week, or they get text messages twice daily. Then after week 4, we assess response. For those who are responders, they are randomized to either stay the course or ramp down the intervention because they're responding, and that's for the next 4 weeks. If they are classified as a non-responder, they either stay the course or ramp up because they need more additional intervention dose. So in this study, which we completed, we had over 80% complete the weekly surveys over 8 weeks, and also over 80% completed the 4 and 8 month follow-ups. In terms of booster engagement, 97% received the text messages and never pressed stop. Now, this is an issue in the field with text messages. How much did they attend to the text messages is unknown. Our prior work showed that it increases burden too much to ask youth to respond, and they don't want to do that. However, in the health coach sessions, they attended about 55%. And what that means is they attended in each phase between 2 and 3 of the 4 sessions. So I thought you might be interested just to hear a little bit about the intervention components. What's shown up here is the text messages. And note both the health coaches and the text messages, again, tend to focus on upstream prevention factors like coping, social support, leisure activities, and resources. Specifically for the text messages, we developed these iteratively. We have a bank of over 1,000 text messages that were refined by, every message was rewritten and refined by 4 youth from the community. And you can see here the morning messages really focus on upstream factors such as mood or negative affect, social support, leisure activities, whereas the afternoon messages tend to focus more on harm reduction, including avoiding substance use and violence. I wanted to mention that one thing that the youth came up with that I thought was pretty cool is that each Sunday youth wrote in the survey, they write a message to themselves about to remind themselves of their strengths and their values, and then that message was sent to them on a Thursday. And we do have that qualitative data, but I don't have time to present it. It's pretty interesting. So what do we find? So we found about 40% in each arm based on stage 1 randomization were responders, and that was not significantly different in this comparative efficacy study by stage 1 randomization. We also found that we did not find significant effects on stage 2 randomization either, and that's probably reflects the underpowering. However, as shown in these forest plots, overall, the conditions, there were significant reductions in over time for almost all of our outcome variables, particularly at 8 months. And the magnitude of these reductions was larger than in our original trial of just Safer Teens alone. So we concluded that this is pretty promising and shows that digital boosters are potentially promising for youth. And we're hoping our future analyses will sort of give us clues of who might need more intensive interventions so that we can seek further funding to expand this. I did want to note that I also have some implementation science work with youth violence prevention on the west side of the state, but I don't have time to talk about that today. All right, finally, the last project, we have a pilot project that tested an M-Health intervention app called MyWaves. I wanted to note that Dr. Billy Nahamshani, who's the PI of the P50 funded by NIDA at D3C, is the head of the study, and Dr. Lara Coughlin is the PI of the pilot study. She's sitting right here up front. The goal of this study was to develop a personalized, just-in-time adaptive intervention, and this is called P-JEDIs, to help reduce cannabis use among emerging adults. Note that a personalizing JEDI in the course of this study means that during the intervention, there was continual learning via a reinforcement learning algorithm, which is a key innovation over standard JEDIs. Standard JEDIs usually use static or fixed decision rules to inform tailoring, and those decision rules do not change over time. So in the MyWaves MRT, participants are randomized twice daily over 30 days to receive a therapeutic message or not. And we're looking at the proximal effects of messages on engagement and cannabis use in the next 12 hours. So briefly, in terms of the flow, twice daily, there's prompts to complete a survey. There's a decision point in which they're randomized to receive a message or not. And then the survey window closes. Based on time of day, recent cannabis use, and app interaction, the RL algorithm will use each participant's prior data to adjust the probability of whether they should deliver a message or not, with the goal of maximizing those outcomes. Developed with youth advisors, MyWaves features these self-monitoring. I thought I'd show you some app features here. You could see the self-monitoring is not just substance use, there's other features as well, things like sleep. Then it includes a reward card with a reveal to show their incentive for self-monitoring, which is very small, usually around $1. There are trend graphs, resources, therapeutic messages, and one of the things the youth told us in prior work is they want to save the intervention messages they like, which means some they don't like, but it means that they really, there are certain ones that they want to refer back to later, so that's a feature we added. The content of the messages, and I think this is really important in digital health, is based on theory for behavior change. And that way, the messages focus on affect regulation, alternative cannabis-free activities, and future goal-directed thinking, which are all evidence-based theoretical reasons that affect youth substance use. In addition, we decided let's examine other features of the messages. So if they were randomized to a message, we also did a 2x3 of the type of message they could get, so we could explore that on proximal outcomes. Basically, we varied short and long, and then how much the interaction was requested in the message. So it either was click to acknowledge, a link to external content, which they could go read, or a text box to type response. So basically, we were curious how burdensomeness might relate to the efficacy of messages. So what did we find? So this is a paper we just got to revise, resubmit on. Findings show that the app was feasible and acceptable. Almost 80% complete the surveys. They like the messages. Importantly, we were really excited in the MRT that receipt of a message did increase proximal engagement after message receipt. So that was super exciting that we found that. We also explored in terms of message length, it doesn't seem to matter, right? Short or long didn't matter. However, less burdensome messages, which is the click to acknowledge, it appeared to be more promising than more burdensome messages. As this was a pilot study, unfortunately, we did not see effects on cannabis use outcomes in the next 12 hours, although we weren't expected necessarily to given the power in a pilot study. However, we did see significant decreases in cannabis use over the 2 months of the study. As for next steps, we hope to expand this study into a larger multimodal adaptive intervention. I'm particularly curious about combining this with some of our human-delivered components and to see how we can sort of best optimize in terms of who might need what and test it in a hybrid experimental design. So that's my dream for a future grant proposal. So in conclusion, and thanks for hanging in here with us. I know it's like the end of the day and there's been so much wonderful talks. I wanted to just briefly mention a few key challenges and opportunities. You know, Erin and I believe that there is no one best approach for intervention delivery. And it really depends on partnering with your community members, whether that's the youth, the family, the caregivers, in terms of clinicians, and really think about selecting a modality that is going to work best for that population, for that problem severity in that setting at that time. And the reason is because we want to maximize translation, right? Because we want to have an impact. Of course, such individual level interventions are only one piece of sort of a broader puzzle of community interventions. And as some of my work combines our interventions with interventions at the community level, like greening interventions and things like that. I didn't have time to talk about that today, but I just want to mention that we're sort of focused on individual level interventions here, but there are also a whole suite of other interventions that we can also think about taking our work and partnering and combining with. Next, I think I mentioned, you know, our studies tend to be 30 days as our intervention, or sometimes 8 weeks, 2 months, but people's concerns and problems and challenges might last their lifetime depending on the concern that they have. And there are times that it's maybe more bothersome and times that it may be less bothersome. And so really thinking about how can we do that, both in a scalable manner that could be translatable. And I feel like that's where adaptive interventions really could apply, because you could sort of up things when they're needed, and in a perfect world, then you could sort of step down when it sort of wasn't needed, and that would allow preserving resources for people when they needed it more, but also some individuals may need it more consistently. Another thing to think about, of course, is the integration of PJEDIs and Gen AI. You know, Gen AI, whether you integrate that as a feature in an app, like I'm hearing people that are doing, Chandra Sapata has an app in my department. He does work where he has an app to do diaries. So you can do audio diaries and then it'll give feedback to people on that along with graphs and things like that. That is an app feature, and that's really cool. And how can we integrate things like that into apps? As well as what role does Gen AI have into these complicated RL algorithms? And that is above my pay grade, but that I know is coming. So, and that's something I had mentioned like to Walter. This is an exciting direction of the field, and it'll be, I'm just so excited and curious to see how that plays out regardless of health condition. Finally, you know, for any of you who have developed an app, it's hard. I moved on to the next slide, but that's okay. It's, you know, apps are costly and time intensive, and the D3C and a couple of people had mentioned, Libby had mentioned this on our slide earlier, you know, go there if you're interested. There's a platform they're developing called Justin, which could help to sort of create this and make this more simple and so forth. So please feel free to go there. I want to give a thanks to everyone who helps us, the youth, the caregivers, clinicians, staff, all my collaborators, many of whom are here in this room. And thank you very much. We're happy to answer questions.
I want to commend you for having 3 different advisory groups. What do you do when they're in conflict in their advisory?
We ask them. So I think what we'll do is, because we don't, logically they don't happen all 3 at the same time, right? Like, and we do, our advisory boards meet all three meet twice a year. But in addition, they are so sweet that they let us send them questions. So sometimes if we have a design decision that we're trying to make in between the times that we set meetings up, we will send them like a little QR code or a link, and they will go to a Qualtrics survey and we're like, hey, we're thinking of increasing our age group to this. What do you think? And they'll reply, and that way we can have sort of rapid feedback. And then we give that feedback to the next advisory board meeting and said, well, the caregivers or parents are thinking this, or the healthcare clinicians are thinking that. And so we really let them help us make those decisions. And we also tell them they have a lot of good ideas we're not allowed to do. Like payment options. We could have a conversation over how you pay people in digital health. But anyway, but yes, thank you for that.
Yeah. Just a general question. I've been reading and hearing that alcohol use in general amongst the maybe under 30 age cohort is on the decline. But it's interesting that you mentioned that there's a lot of commingling with cannabis use, and the question is and the cannabis use in turn may be depending upon the delivery mechanism, like through vaping or something, and that's perceived as being less unhealthful than drinking. I just wonder if you have any comments on this relationship that you found between cannabis usage and alcohol. Thank you.
Well, not necessarily a relationship that we found, but we know that a lot of our work is with adolescents and emerging adults, and so that is the time in which you see more experimentation with substances, right? And you see more trying of different things. And so you're absolutely right that the prevalence of alcohol use is declining, but cannabis use is increasing in prevalence. And we're just always going to have some people that use more than one thing, just like we're seeing a lot of cannabis and tobacco overlap. A lot of times, our interventions address motives. And so it's why are you using and what other ways can we address those issues? So I don't know if that answers the question, but it sort of speaks to kind of how we're thinking about it, upstream motives. Yeah.
Thank you. And Abby Bretson, Injury Prevention Center here. Thank you all for your talk and the talks throughout the day. And one question I have, because it's recently come up with some clinicians, is do you talk about issues with risk management in the types of questions or prompts that you're asking, and who's actually monitoring the data? A lot of what we're talking about is building data systems to collect data, but on the back end, who's monitoring it to see if problems do arise that may or may not be related to your intervention?
Want me to take that as the clinician? Licensed. Maureen is a clinician at heart and does as much of this as I do. But so I think there's a few issues there. So there's data that's being collected as part of an intervention, and then data being collected as part of, let's say, research assessments. In terms of our interventions, when we have our human-delivered interventions, there are people paying attention actually to that data. If someone wrote in Snapchat, I'm feeling really low, I'm having a bad day, have certain words, we would reach out to them and conduct a risk assessment, which is pretty standard in our work in clinical population. So in one way, we manage that by having folks on call. There are a lot of surveys and studies in the world that ask high-risk questions that don't monitor the data. I'm not going to say what personally I feel about that, but that is something that we kind of take seriously, is that we are peeking at the data over time and looking at it to some degree, but we also tell participants we're not monitoring this 24/7. This is not the place to go for an emergency. We have flags across sort of like on our portal webpage. When you log in, there's a crisis line at the top. There's that reminder. And y'all know this. You've probably called Michigan Medicine before. If they say on any time you're on hold, if there's a crisis, you call 911 or you call something else instead. So it's very similar to clinical care in that regard.
Thank you, guys. It was really clear what a thoughtful and sort of nuanced understanding you have in this really specific area. And really cool to hear about the really massive empire of work that you have spanned up there. Yeah, very impressive. Those slides with like just all those papers you've written were just overwhelming. But so my question for you is, you have sort of outlined this career. You covered so many studies and so many projects, finding so much work across largely young adult populations and reductions in risk behaviors. And I'm curious if you can speak a little bit to, if you're an earlier in your career trainee, or you're just earlier in your career, or earlier pivoting into this space, have been here today learning about mHealth and really want to try to do it, what are some steps, you mentioned Justin through D3C, but that you might be able to, take this into your own content area that you might be interested in, whether or not that be young adults and risk behaviors, and start a line of work like this?
Which one of us are you looking at?
Go an eye on both of you.
Well, I'll say that I think conferences like this one is sort of the first thing that came to mind. So like that session earlier where you had all those people going up, and like CHCR was there, and people saying that they're different services and things they have. Justin is just one service. CHCR is a service. There's a lot of options across campus. And I think the point is to create this kind of learning community where we can all learn from each other, because it's hard. This is hard work with, we're trying to help people, but this is challenging. And so I think learning and partnering with other people in the room. So if there are people here today that you heard a talk from, like reach out, email them. I always say email someone for a coffee chat, right? Like they'll meet you for 30 minutes via Zoom for coffee at a very minimum. So, I think that's kind of the main thing, is I would say reach out and partnering. And I think Walter said that when, Kathy, you asked like an amazing question. And I was like, how would I answer that question? So I'm going to take Walter's question, a page from his book. Like it takes that teamwork and that collaboration, because you can't do this work otherwise, in my opinion. So.
Ditto.
All right. Thank you so much, Maureen and Erin. That was amazing. Greatly appreciated. Another round of applause.